This is the beginning of the lecture on imaging of the cranial nerves. This is a very long lecture. It's got almost 150 slides in it, but we'll break it up into 12. Well, it's obvious how many parts we're going to break it up into. Here are the 12 cranial nerves. I know that there are some mnemonics that people prefer, some of which are appropriate to a YouTube video and some of which are not appropriate to a YouTube video. Either way, I don't find those mnemonics very useful. I think that by using the words in your dictations, you'll quickly become familiar with them, and you won't need the mnemonic anymore. We're going to march through each of these in the order listed. This is a drawing of the brain as seen from the undersurface looking up, and it really shows the origin points of the cranial nerves well. This picture happens to come from my favorite book on the cranial nerves, the Sandow's book that was published in Hong Kong in 1988. I doubt it's possible to get a more recent printing of it. Great book, though. Really does a great job of the anatomy. No radiology, but shows the anatomy really well. It does a good job of showing each of the cranial nerves, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12, all laid out very nicely on a single image. Let's begin with the first cranial nerve, the olfactory nerve. Really, the clinical finding that points towards the olfactory nerve is anosmia, the inability to smell. Not much else going on with this nerve. There are some key concepts, though. When you have olfactory nerve dysfunction, it usually presents as dysfunction of taste because the majority of our perception of taste actually relies on the smell of the object. It tends to be a late presentation in injury to the nerve, especially because of the redundancy of having the two nerves. Remember that the olfactory nerve is actually not a peripheral nerve. It is a white matter tract, and it contains no Schwann cells. Here is a coronal, strongly T2-weighted sequence that shows the olfactory nerve in the olfactory groove. So these are the olfactory nerves. They're sitting in the olfactory groove at the anterior skull base. Here's the crista galli separating the two olfactory grooves from each other. And you can see that when you get to the olfactory bulb, these nerves actually get fairly large. What's going on here is the nerve is sending down small sensors across the cribriform plate of the anterior skull base, where those chemoreceptors will trigger the olfactory nerve. If we go a little further back and we more posterior onto the level of the planum sphenoidale, you can watch the olfactory nerve continue in between the gyrus rectus and the medial orbital gyrus of the frontal lobe, and you can look for the olfactory nerve in that location as it heads back to the brain. In the axial plane, you can see the olfactory nerve on a high-resolution T2-weighted sequence going from medial to lateral. We're in the orbit here. Here's the lamina papyracea. We're coming through ethmoid air cells. We're at the lateral lamella of the cribriform plate. Now we're into the olfactory groove, and there's the olfactory nerve running along the olfactory groove surrounded by CSF. We hit the crista galli and we're on to the other side. So that's the axial anatomy. One of the major things that can go wrong with the olfactory nerve is congenital anosmia. This is usually a diagnosis that presents in childhood, but not always. Some people make it to adulthood without realizing that they haven't been tasting anything their whole life. Here is another coronal, heavily T2-weighted image. This is a steady-state free precession image through the anterior skull base, and you can see that those olfactory nerves that should be sitting here in the olfactory groove are notably absent. Nothing but CSF in the olfactory groove. That's the imaging finding for congenital anosmia. It's a aplasia of both of the olfactory nerves. Here's a mass occurring in the anterior cranial vault, and you can see that this mass is of intermediate T2 signal similar to brain. It's surrounded by some displaced sulci, and it's really filling the olfactory groove there. It's a lot easier to make the diagnosis on a post-contrast coronal image, where you can see that this heterogeneously enhancing mass is filling the olfactory groove and spreading across the anterior skull base. This is a classic location for a meningioma, so classic in fact that it has its own name. This is called an olfactory groove meningioma. You can imagine how this would impinge upon the normal function of those olfactory nerves. Here's a similar looking image. This is an axial T2 weighted image, and there is a intermediate T2 signal mass filling the anterior skull base. This one looks a little different perhaps because it has cysts formed along the cranial surface of the mass. That's a classic Aunt Minnie finding for this diagnosis. When we switch over into the coronal plane, very similar to the last case, but instead of preserving the skull base and showing us exactly where that olfactory groove is, this mass completely destroys the anterior skull base. It erodes through that olfactory groove. None of that anatomy is present. This is a transcranial mass, and once again you can see these small cysts along the superior surface, along the cranial surface of the mass. That is a clue that what we're dealing with here is esthesioneuroblastoma. Anytime you see an aggressive mass in the anterior skull base that has traversed the bone of the skull base to be both intracranial and intranasal, you should always think about esthesioneuroblastoma. Certainly other aggressive masses like squamous cell carcinoma and melanoma can do that in this location, but the classic lesion to do this is esthesioneuroblastoma, and the small cysts along the cranial surface are essentially pathognomonic. Remember that in order to smell things, even if you have a normal olfactory nerve, you need to be able to get the chemoreceptors active along the cribriform plate. If you have mucosal disease filling the olfactory cleft, then the air can't get up to the cribriform plate and you can't smell anything. This is the normal side where there is air filling this olfactory cleft, and this is the abnormal side where there is tissue, generally mucosal thickening, although certainly you can have an encephalocele in this location as well. Generally it's mucosal thickening filling the olfactory cleft. To review the anatomy one more time, olfactory groove up here, normally filled with CSF and an olfactory nerve. Then there's the horizontal cribriform plate, and then below that is the olfactory cleft. Some people call that the olfactory recess. Those are synonyms. I kind of like olfactory cleft. Number 2, the optic nerve. It's pretty obvious when the optic nerve starts to go wrong. People are quick to complain when they have double vision or field defects. Also, pain within the orbit can be an indicator of optic nerve disease. Some key concepts to remember about the optic nerve. First of all, it's not a peripheral nerve at all. It is an extension of the brain's white matter, a white matter tract that extends outside the brain. It has no Schwann cells. Its myelin is supplied by oligodendrocytes instead of Schwann cells, as would be the case in a peripheral nerve. Remember that the optic nerve is surrounded by a dural sheath that protects it from the surrounding fat or bone, and that there is CSF around the nerve, between the nerve and the dural sheath. The optic nerve has a bottleneck at the optic canal. That's the canal specifically designed for the optic nerve, but it's a tight point along the path of the optic nerve, and if you're going to get compression of the optic nerve, that's the most likely site for it to occur is in the optic canal. There are 4 anatomic segments of the optic nerve. From anterior to posterior, they are retinal, orbital, canalicular, and cisternal. The retinal segment of the optic nerve is a short segment that is where the retina coalesces into the optic nerve, and all the fibers from the retina come together at the optic disc and form the retina. It's very thin. It's just along the wall of the globe itself. And then once we get outside the globe, then we're in the orbital segment. This is what most people think of as the optic nerve, as it traverses the orbit from the globe to the apex. But that's not the end of the nerve. The nerve continues on in its own personal canal, the optic canal, where it is tightly surrounded by bone, and then it emerges into the suprasellar cistern, the cisternal segment. It crosses the cistern to meet its counterpart from the other side and form the optic chiasm. If you like the prefix intra, you can rename each of these segments intraocular, intraorbital, intracanalicular, and intracranial. I'm not that big a fan of that prefix, so I kind of like these shorter versions. Here we see the segments of the optic nerve in action. This axial image was particularly lucky because you can see the entire length of each optic nerve on one image. You don't usually cut it that well, but that's why I chose this image. So here's the retinal segment right at the back of the eye, right? You can see it's not actually the focal point. It's a little bit medial to the focal point. That's the optic disc. So the retinal segment's just right here. And then this is all the orbital segment as it traverses most of the orbit. Then it dives into its own personal canal, the optic canal, which runs from about there to there. That is a tight, bony canal for the optic nerve. And then it emerges into this cistern, the suprasellar cistern, before joining with the chiasm. These two pictures are probably the most important images to understand in the entire lecture. This is the normal appearance of the optic nerve on a fat-suppressed coronal T2 weighted image and a fat-suppressed contrast-enhanced coronal T1 weighted image. You have to understand this normal anatomy to be able to pick up pathology, and when you see asymmetry, to know which is the normal side and which is the abnormal side. This appearance of the optic nerve on the T2 weighted image has been termed the target sign. You can see the dark nerve in the center. It is surrounded by a bright ring of CSF, and that is surrounded by a dark rim of dura. That dura is indistinguishable from the surrounding suppressed fat, but it's dark along with the fat. The target sign is a normal appearance, and this is about the normal size of that optic nerve. Sometimes there's a little less CSF, sometimes a little more than what you see here, but this is sort of average. Notice that the extraocular muscles are well seen here, but they aren't nearly as bright as the CSF, but they're still distinguishable from the surrounding suppressed fat. When we move to post-contrast imaging, the extraocular muscles really pop out. Why? Because they are extremely vascular muscles. They're very red fiber rich, they're fast twitch muscles, they're very vascular, and so they have a lot of enhancement. That's normal. We want those nerves to show up like that. In contrast, the optic nerve and its sheath fades into the background here. You can barely see the nerve against the surrounding suppressed fat. That's normal. So it should be very easy to see the nerve on a T2, and it should be very hard to see the nerve post-contrast. So here's a patient with a clear asymmetry within the orbits. On this side, the optic nerve sheath complex is bright on T2, and on this side, it's got our target sign. On this side, there's a clear asymmetry where the optic nerve looks a lot like the extraocular muscles on the right, and it fades into the background on the left. So you've got to know which of these is normal. This is the normal one where the optic nerve fades away, and this is abnormal where the optic nerve is enhancing. This is normal, where the optic nerve makes a target sign, and this is abnormal, where the optic nerve is whited out by edema and is indistinguishable from surrounding CSF. Actually, it has probably swollen to the point where it has displaced that surrounding CSF, but it's visually indistinguishable. This is optic neuritis of the right eye. It's inflamed, it's enhancing, and clinically, this is, of course, very painful. Now, when I say optic neuritis, you say multiple sclerosis, right? These two diseases are very tightly linked. About half of people with optic neuritis will end up with a diagnosis of multiple sclerosis, and about half of people who eventually end up with a diagnosis of multiple sclerosis presented with optic neuritis. So a very tight relationship. We think about optic neuritis as affecting the orbital segment of the nerve, which is what's shown on the previous slide. But remember to look at the other segments of the optic nerve. One of the most important reasons to talk about the 4 anatomic segments of the optic nerve is to remind you to look at each of those segments every time you are called upon to assess the optic nerve. For example, you can get optic neuritis that affects only the retinal segment of the nerve. We call that papillitis, and here it is. It's a small focus of enhancement right at the optic disc. That's papillitis, and it's a form of optic neuritis. It's just the retinal segment of the optic nerve. You can get optic neuritis in the canalicular segment of the nerve. It's really easy to overlook this area, especially if the orbital segment of the nerve is normal. You have to remember to look at each segment of the optic nerve whenever you're looking for a diagnosis like this. It's the same basic findings. You can still see the dark nerve surrounded by CSF on the normal side. Actually, as you go through the canal, often that CSF is not visible, but here at the front of the canal, it's still visible. And you can see that that's whited out on the affected side. There's no nice dark nerve. It's just bright signal. On post-contrast imaging, that segment, this canalicular segment of the optic nerve is enhancing, should look like that, no enhancement at all. Symmetry is your friend here when trying to decide whether you're looking at vascular enhancement or the nerve itself. So this is another form of optic neuritis affecting the canalicular segment of the optic nerve. Let's move on to masses that affect the optic nerve. The lesion that arises from the optic nerve itself is a glioma. It may seem strange for a glioma to arise from a cranial nerve, but remember that this nerve, this second cranial nerve, is not really a peripheral nerve. It's really a white matter tract, and so the abnormalities that affect this nerve are actually abnormalities of white matter, such as gliomas. Thankfully, these are usually juvenile pilocytic astrocytomas that arise within the optic nerve. You can see that there is a large structure on the T2 where the optic nerve should be. It's abnormally bright in T2 signal and enlarged, and you can still see a little thin rim of CSF around the periphery. Here you can see how much this mass enhances, and you can still see that little rim of CSF that has been displaced to the periphery. This is enlargement of the nerve itself, and that is the important clue that we're dealing with a glioma. Here's glioma seen in another perspective, enlarging the optic nerve and its entire nerve sheath tract, the normal nerve on the other side, and you can see it extending back into the chiasm. Here's a coronal example of a glioma affecting the chiasm. Remember that the optic chiasm should be, I don't know, a quarter of the thickness of this object. This is hugely thickened by glioma. Now we're going to contrast the glioma to a meningioma. Instead of enhancement of the nerve itself, a meningioma enhances along the dural sheath. It's an abnormality really of arachnoid, but it appears as an abnormality of the dural sheath, and there is a rim of enhancement around the nerve itself. So there's the preserved nerve in the center. Remember, it should be blending in, similar color to the surrounding fat. There's the nerve in the center, and this enhancement around the periphery, this halo of enhancement, is characteristic of meningioma. It's also characteristic of the neuritis form of pseudotumor, but we'll talk about that in a different lecture. So this is what meningioma looks like when it arises from the dura of the optic nerve sheath. This is what it looks like in axial cross-section. You can see meningioma on either side of the non-enhancing nerve down the center. This has been called a tram track sign. Sometimes it's difficult to identify whether a mass is arising from the optic nerve itself or whether it's arising from the surrounding structures and crushing down on that nerve centrally. This is an example of a patient with decreased vision and a mass at the expected site of the optic nerve. I'm going to hammer this next point home a lot. This side is the normal side where the nerve blends into the background. This is the abnormal side where you can actually see the nerve. It's abnormal to actually see the nerve on these coronal post-contrast images. So is this a peripheral mass crushing the nerve centrally, or is this a central mass pushing the CSF out? Well, if you go to the periphery of the lesion, the problem here is we're in the center of the lesion, it's hard to tell. If you go to the periphery of the lesion, here's where you can see that in fact there is enhancement around either side of a preserved nerve. It's hard to appreciate that on the last side in the center of the mass because the nerve is so crushed down by the mass itself, but when you get to the edges you can see more clearly that this is actually a meningioma. So, where are we likely to compress the optic nerve? We're likely to compress the optic nerve at the bottleneck, and the bottleneck is the annulus of Zinn, which is where the extraocular muscles, 5 out of the 6 extraocular muscles, attach at the apex of the orbit, and then from there back into the canalicular segment. So at the annulus of Zinn and intracanalicular are the sites where the optic nerve is most likely to be compressed just because it's surrounded by dense, tough material in those locations. Here's an example of a patient with metastatic disease to both sphenoid buttresses, and you can imagine where compression of the optic nerve is going to be a problem right here. This is not going to be a problem because all the fat will just get out of the way and you won't have a crushed nerve. This is where the problem is at the optic canal. This sort of mass can be surgically decompressed to permit the optic nerve some space, even without resecting the mass itself. You can decompress the opposing surface of the canal. By the time we see papilledema radiologically, we are at a severe form of the disease. Fundoscopic examination will recognize papilledema long before radiology will, much more sensitive than we are. But in extreme cases, you can see flattening or even inversion of the optic disc as an indicator of increased intracranial pressure. This ends part 1 of our lectures on imaging of the cranial nerves.